Hello.
Yeah.
Yes, sir. Please go ahead.
Yeah. Good evening, everyone. So I'll start with the case. 29-year-old gentleman, resident of Jalgaon, carpenter by occupation, came with chief complaints of progressive weakness in all the four limbs since
Sir,
last 4 years.
little loud and a little slow.
Okay. So came with chief complaints of progressive weakness in all the four limbs since last 4 years and thinning of muscles in all the four limbs since last 6 to 8 months. So patient was apparently all right 4 years ago when he started noticing upsquatting difficulty. Yes,
Saurav, sorry, can we stop here
Yes.
for a second? You go back to the chief complaints.
Yes.
I think it's always a good idea to start formulating in your mind the hypothesis with which you're going to work. So, can we ask, whom can we ask? Dr. Bhatt, Prakash Bhatt.
Yes, sir.
What comes to your mind with these two chief complaints? What comes to your mind?
Sir, progressive weakness in all the four limbs since last 4 years. With thinning of muscles recently, probably there is it is related with the motor dysfunction. Either
Correct.
it can be anterior horn cell disease or it can be muscle disorder.
So you have made up your mind that it's a lower motor neuron disease. Why?
With these two complaints, sir, because thinning of muscles is related with the lower motor neuron disease.
But see, the thinning has come 3.5 years after the weakness has come. Even the upper motor neurons will get thinned out eventually. So, do you need to keep upper motor neuron also?
I'll keep motor system disease.
Correct.
I'll keep it as motor system disease.
Yeah. I think it's good to keep everything and then go on dissecting and then coming down to finally where you want to be. Sometimes you will be surprised how thin the spastic weakness is as years go by. Okay, so let's go ahead.
Okay. So patient was apparently all right 4 years ago when he started noticing initially upsquatting difficulty. Then he started noticing difficulty in getting up from ground while sitting, using his hands to push his body off the ground. Over next 6 months, he started noticing difficulty while walking upstairs. He used to make use of railings while getting up from low chair, and there was increased difficulty while getting up from ground. Then over the next 1 year, he started noticing difficulty in wearing and holding chappals while walking, and along with slipping of chappals with knowledge. During the same time, he also had difficulty in lifting the foot while walking. Used to lift his leg high up the ground while walking. He also started having episodes of tripping with falls while walking on uneven surface. He started walking slow and gradually requiring more and more support while doing so. Now, since last 2 years, he started noticing weakness in upper limbs, left followed by right within an interval of 2 to 3 months. He had difficulty in performing activities of overhead abduction, like combing hair, bathing, wearing t-shirts, lifting heavy weights. So predominantly overhead activities. Gradually, he started noticing difficulty turning in bed, getting up from sleeping supine position, and also lifting his head while doing so. Since last 8 months, he observed thinning in muscles of thigh and arms on both the sides, but it was not associated with any twitchings. Now, since last 6 months, he has difficulty in performing fine activities with both his hands, like buttoning, unbuttoning, holding objects, inability to open the lids, more so on the left than the right, accompanied by thinning of both the hands as well. No history of any, so this was a positive.
No. Before you go to the nose, you want to sum up what you said?
Yeah. So he's basically 29-year-old gentleman with progressive weakness, which started in the lower limb, proximal. Then over next 1 year, went distally in the weakness in the foot, and then over next 2 years in the upper limbs, which started proximally and then distally. And the thinning of muscles started very late, like in last 6 months.
So, so Vikram, you want to analyze this?
Yes, sir. So basically, since 4 years, he started with proximal lower limb weakness, and over time, he has gone to develop a predominantly limb girdle pattern, then a truncal weakness, and then distal muscle weakness. Distal lower limbs followed by upper limb weakness, and there is no facial or bulbar involvement, no respiratory involvement as such. So the phenotype is like a limb girdle dystrophy, but with early lower limb distal weakness. With wasting, which has come quite late. So before anterior hornsel, I like to consider muscle over here because the wasting came later.
Right.
Then the other possibility is the anterior hornsel, since it has started around 25 years age. So adult onset SMA is one possibility.
Yeah, anything?
Looks.
Yeah, go ahead. Yeah.
Yes.
So when you said it can be even anterior hornsel.
Yes.
The history suggests more like a symmetrical, although even though the thinning has come, it has affected symmetrically both all four limbs and has come, as sir said, quite late in the illness. So I think more than anterior hornsel, myopathic ailments are still more likely here.
Right.
Although we know the cases of myopathy, but still, because the wasting has come symmetrically. So because in anterior hornsel, it will be more of asymmetrical. There has to be some history of asymmetry as far as thinning is concerned.
Correct. I mean, for those who are maybe early in neurology training, when you think of an anterior hornsel disease, in your mind, you have an image of motor neuron disease. But if you keep the image of spinomuscular atrophy as an example of an anterior hornsel disease, then you will see how difficult it gets to try and differentiate anterior hornsel from muscle. Anterior hornsels, like SMA, can sometimes be quite symmetric. But the point that Dr. Rakesh Singh made is very important, that if you see asymmetry, you slightly tilt towards an anterior hornsel. So coming back to this patient's history, what are the hallmarks here? When has the disease started?
Third decade.
So it's a third decade disease. Right. You think it's a progressive disease?
Yes, it's a slowly progressive because
why
one after the other. Because the symptoms have progressed from one side to the other side, like the proximal lower limbs, then lower limbs, distal lower limbs, then the truncal muscles, and then the arms, distal arms.
Again, as a general comment, I want to emphasize this, that progress in neurological diseases means new structures getting affected or the structures that were already affected getting worse. And here is the specter of spasticity. People who are spastic can go on becoming more and more spastic when the disease is not progressive. So everything that produces more and more disability doesn't necessarily mean a progressive disease. But here you have shown that new things are getting affected. And therefore, you are sort of on more firm grounds that this may be a progressive disease. So what sort of disease do you have in mind? Prakash, what sort of disease do you have in mind?
Sir, with this history, 4 years of slowly progression from the low limb proximal, then the low limb distal, then upper limb proximal, followed by proximal weakness with truncal weakness. It looks like, sir, muscular involvement only.
Right. Right.
Because functional deficit, he is unable to, his activities of daily living is impaired.
So you are making points for a myopathy. Somebody made points for anterior hornsel disease. Is any other localization to be considered? It's a question from one of the participants. What about nerve? He says, what about nerve? Could this be a neuropathy?
Now, usually presents distal weakness, pure motor neuropathy.
But tell me some proximal neuropathies.
Sir, chronic inflammatory demyelinating CIDP.
Absolutely. CIDP can start in the thighs.
No, sir. It will not start in there, but it can affect the proximal muscles.
So, haven't you seen a GBS starting in thighs? A GBS starts in thighs, CIDP starts in thighs. There's nothing preventing a demyelinating neuropathy from starting anywhere. It's a non-length dependent process. What are the keywords in acquired demyelinating neuropathies? Focal and segment. They can start anywhere. But could this be a neuropathy? That's the question asked to us.
There are a lot of odd points for that.
The answer is that it could be,
It could.
but you will consider it lower down. And you will consider it lower down because the patient hasn't come up with anything sensory. Is that possible? Is it possible that the patient doesn't come out with sensory and you try and examine and you find a lot?
Yes, sir.
That's very much possible.
Yes, sir.
8% of patients can have a pure motor CIDP.
There is that situation of pure motor CIDP, even though it's a difficult disease. You don't know what that disease is. But Dhaval, in which conditions patients don't complain of any sensory features, but you examine and you find a lot of sensory, which can happen in this patient.
Can you please?
Sir, hereditary mainly, sir. Charcot-Marie-Tooth
Very,
disease.
very slow neuropathy.
Slow neuropathy.
Very slow neuropathies, particularly the inherited ones, where patient doesn't complain and you find a lot and they are wasted, they are slow, they are distal and proximal. So there is room to say that, okay, maybe, but you're going to put it lower down because it started in the thighs and then went to the foot drop. Okay. So, Bhagyadan, you want to make any comments at this stage or shall we go ahead with the negatives?
Sir, since the point of the arise that neuropathy can be one of differential and we are dealing with a pure motor dysfunction. So can Prakash, can you say some neuropathies which are pure motor in nature, which do not have any sensory involvement?
Yes,
Can you
sir.
name some pure motor neuropathies?
Multifocal motor neuropathy with conduction block.
Okay.
Then lead poisoning neuropathy, sir.
Common. Any GBS variant can present with pure motor dysfunction.
So GBS, Aman, sir,
Can present.
acute Aman variant.
Any metabolic neuropathies that can have only motor involvement?
Pure motor. No.
Porphyria?
Porphyria, yes.
Predominantly motor neuropathy.
Yeah.
Sir, if I may add one thing.
Yeah,
Now,
please.
since the question of neuropathy as a localization has come, now the points odd here will be, despite having so much of weakness, motor weakness, there is absolute lack of sensory complaints. That is one thing which is little odd for a neuropathy.
Correct.
Secondly, 4 years and now 1 year upper limb, the history sounds more like a length dependent neuropathy, if at all it is a kind of neuropathy. Now, length dependent neuropathies with so much of motor involvement are a little odd. I mean, there are like length dependent demyelinating neuropathies like anti-MAG and those antibodies, which are more sensory ataxic rather than so much of motor. So I think neuropathy, of course, can be raised as a discussion.
Right.
But
What you're saying is you'll keep it lower down. For the reasons that you mentioned. Yeah.
Also, sir, other points like the history of showing the Gowers maneuver. He was literally climbing up on his body as per the history. So that is again favoring more of a myopathic pattern. But in the history, I would like to ask, Saurabh should have asked about the history of any hypertrophy or lumpish appearance or any differential patterns, like Gowers you have asked. Gowers will really point towards the myopathic ailment. So
In the negatives, I'm going to cover some. But that's right. I mean, these points that Dr. Rakesh Singh is mentioning tell you which is more likely and which is less likely. Yeah.
And sir, before we go ahead, any possibility of limb girdle myasthenia?
Yeah, that's the question that has been asked by 2 or 3 people.
Okay.
Could this be limb girdle myasthenia?
Myasthenia, I mean, rare disease, but because it is treatable.
So who answers? Saurabh.
Yes, sir. So the history is very slowly progressive, starting in lower limbs and then upper limbs with wasting. So it
Mm.
looks less likely a NMJ syndrome.
Mhm.
There's
One
no
point I want to make.
fluctuations.
See, the
And there is
answer
no
is,
fatigability, sir. Uh,
yeah,
no fatigable and variation in the weakness, diurnal variation.
yeah. The answer is that it could be,
Yeah.
but
Yes.
you will keep it below neuropathy.
Yeah.
Why will you keep it below neuropathy? Number one, it is a very rare disease. See, if you look at neuromuscular junction disease in a third decade going on for 4 years, untreated and slowly going on, you are probably not thinking of an immunological disease. If an immunological disease, you may be thinking like a Lambert-Eaton syndrome, because this is below the neck. Lambert-Eaton syndrome is rare. Or you're thinking of a congenital myasthenic syndrome, which is rare. But when you come to the congenital myasthenic syndromes, they may not have fluctuations. They can have thinning. They can have a limb girdle pattern. Some of them can have a differential weakness. So the answer is it's possible, but it is that much less likely when you compare to the more common garden variety of myopathies followed by anterior onset. So I think there's nothing wrong in keeping this order at this point in time. Some kind of a myopathy first, some kind of an anterior onset disease second, and into brackets, you will consider a neuropathy, and into brackets, maybe double brackets, you will consider a neuromuscular junction. You're not going to exclude it, but you're going to place them like this at this point.
Can I make one point?
Yes, Bhagirath, please.
When you read about articles on limb girdle myasthenia or sir said congenital myasthenia syndrome, that is DOG7, the average mean duration for diagnosis is 8 to 10 years. So
Yeah.
they may not have fluctuations. So what we did when I was with sir, that we used to do repetitive nerve stimulation of every patient with pure motor dysfunction, progressive weakness, and sometimes we may pick up on our empirical genetic study. So limb girdle myasthenia, it is a very fishy thing. We cannot just by say the absence of fluctuations may not rule out. In the end, I mean, after many years also fluctuations may develop. So what sir has said is absolutely true, that limb girdle myasthenia should be considered in the differential, but lower than muscle and
No.
spinal
Yeah.
muscular atrophy.
Yeah, yeah. In some meeting, I was asked this question once: when do you suspect?
Hello.
The answer is you always suspect.
Yes, yes.
The whole idea is to suspect more, and the whole idea is to understand how to place your suspicions in the order of priority. So first is knowledge, the second is ability to place them correctly. Okay, so let's move on. So tell the negative,
Yes.
Saurav.
Yes. So no history of any diplopia, dysphagia, dysarthria, no history of drooping of eyelids, no history of difficulty in closing eyes or eyes remaining open while sleeping, no history of breathlessness on exertion or lying down or any history of palpitations, no sensory or bladder bowel complaints, no associated fasciculations of muscles, no history of stiffness in any limbs, no fluctuations, fatigability or diurnal variations, no history of episodic weakness provoked by exercise or myoglobinuria, no history of difficulty in relaxing the grip or any stiffness in any muscles, no history of hypertrophy of any muscles, no history of cognitive decline or any seizures, ataxia, or behavioral changes, no history of systemic symptoms like fever, weight loss, joint pains, no history of skin rash, and no history of significant history of any drug intake.
Very good. So I think you've covered most of the things. So in view of time, should we dwell here or should we sort of summarize the history in our different and put up our differential diagnosis?
Yes.
Or any other point, Bhagyanan or Rakesh, you want to make?
Let us, I think, summarize and then we'll do
Yeah.
that, sir.
Yeah.
So
There is, I think, sort of family
yes.
history you want to mention before
Yeah,
you summarize?
there is no significant family history.
Yeah. You know, in cases of muscle disease or in cases of anterior onset disease, family history very important. So I think no significant history is the conclusion. But you must tell what is the family like. You must give details of what is the family like, whom all could you examine. You could ask questions about who all. because the primary difference in the classification of myopathies is inherited versus acquired. And Dr. Rakesh Singh will tell you that time and again, when you actually examine the family, you find more people. That there was one patient in JJ who told us that there is no one else affected than the patient herself. But Rakesh made it a point to go to her house. And you picked up how many members? 6 or
Yeah,
7
six.
members he picked up with
That
that.
was a surprise.
So it's a lesson. Family history you can't take casually. You have to ask in great depth because your primary difference in myopathies is inherited versus acquired. It may sound very simple, but medicine is simple. You have to go according to the building blocks. Fine. So at the end of the history, what is your differential diagnosis, Saurav, in the order of priority?
Yeah. So
Order of priority is a very important point.
yes, sir. So first I will keep as a muscle category being dystrophy, muscular dystrophy.
There is
Second,
probably no need to go to that. Just say a
okay,
myopathy. Yeah.
a myopathy. Second, I would like to keep anterior horn cell. And
Okay.
third, nerve.
All right. Fine. Now we go to examination.
Yes.
Or do
So,
we?
sir, at this level,
Yeah.
Saurabh, I wanted to ask you, is there a way to say whether it's a acquired myopathy you're talking about or it's a hereditary myopathy? Any differentiation can you think at this level, 4-year story and youngish man and any
Acquired
pointers to
myopathy, mostly they are subacute, and the time period between upper limb and lower limb involvement should be around less than 6 months. So here the difference is 2 years, and it is a story ongoing since 4 years. So it is
so
less
I
likely
think
acquired,
acquired looks little unlikely.
unlikely.
And of course, when you examine the patient, you will come to know if you find out the differential weakness or hypertrophy, it will favor more of a hereditary rather than acquired. Okay, perfect.
So on examination, general examination, pulse 72 per minute, BP 110/70, significant and asymmetric winging of scapula present, left more than right, and ankle contractures were present. No thickened palpable nerves, no scoliosis of S-cavus, skull spine normal, no skin pigmentation. Higher mental functions normal, cranial nerve examination normal. Single breath count and chest expansion normal. In motor system is thinly built. Can you see the pictures? Hello.
Yeah.
Yes, yes.
Well,
Yeah. So in the pictures, we can see it's thinly built, and there is more prominent atrophy in the forearms, more than the arms, and in the hand, prominently in the first FDI. Thenar and hypothenar remnants are relatively spared.
Just
In the
ask one
legs.
question.
Yes, sir.
You mentioned that there is asymmetrical scapular winging. So, and we are dealing with probably muscle disease. So, can you say name some muscle disease which have asymmetry in weakness?
Yes, sir. FSHD
Yes.
can have, myotonic dystrophy can have,
Okay.
then anectinopathy can have.
Anecto meaning they
Uh,
can present with focal wasting and focal weakness, and then gradually it may become symmetrical.
Okay. And inclusion body myositis can have.
age is odd.
Ages.
Age.
Okay. Fine. Yeah.
And,
So can you say name some myopathies which have prominent scapular winging?
FSHD,
Yes.
in LGMD, scalpinopathy, dysferlinopathy.
Dysferlinopathy is not, but
Yes, sir.
calpinopathy is very, very strong.
Scalpinopathy.
Any other muscle disease? Prominent scapular winging. Dystrophinopathies, DMD, they also have a very prominent scapular winging.
Pompey's disease. Even Pompey's can
Complex
have.
disease. Yes.
Pompey's can have ringing of. Yeah. Okay.
So in the legs, the wasting is more prominently seen lower down in the anterior compartment as compared to the posterior, and the thighs, there's mild wasting seen. And no tremors, no fasciculations or myotonia. There is symmetry in the muscle contour. The tone is normal. In power testing, the neck flexors are weak. Truncal weakness is present. Beaver sign present. Then in the power testing, in the shoulder joint, approximately all are around 4 plus 4 minus. In the elbow, there is some asymmetry in biceps and triceps. Wrist flexors and extensors are 4 by 5. Finger flexors and extensors are also fine. Hand grip and small muscles of the hand are weak.
Can you go back to this slide? In this slide, oh no, the next one.
Yes.
So in this slide, do you get any idea of that whether we are dealing with muscle disease or SMA?
Yes, sir. Triceps weaker than biceps weaker than triceps favors a LGMD over a SM.
Yes, and weakness of triceps more than biceps if that is differential weakness of that. If biceps is preserved and triceps is more severely involved, then usually it occurs. It is not a rule, but usually we get an idea. If biceps is preserved, then and triceps is weak, then possibility of SMA is more likely.
Hello.
Hello.
Yeah, go ahead.
Yeah.
इसको
In the lower limbs, in the hips.
स्टार्ट कर दो और मैं भी जरा मीटिंग में हूँ तो बात
No, go ahead. Go ahead. Yeah.
So in the lower limbs, in the hips, the most severely affected are the adductors. There is a differential weakness. The gluteus adductors are 4 by 5. The adductors are 1 by 5. Then in the knee also there is differential weakness. The quadriceps are spared. The hamstrings are 1 by 5. And at the ankle, the tibialis anterior is affected more than gastrocnemius. So the pattern of weakness more prominently found in the lower limb, the differential weakness in the hips, adductors more than abductors, extensors more than flexors. In the knee, hamstrings more than quadriceps, and in the ankle, dorsiflexors more than plantiflexors. So most prominent weakness in hip adductors and ankle dorsiflexors and quadriceps are spared. In the upper limbs, asymmetric winging and no specific pattern was found. But as sir said that triceps more than weaker than biceps points towards SMA. The reflex.
I want to make a comment that you got these various things, that this muscle weaker than the other, wasting more than weakness and all that. But don't stick to one. Take the whole thing in perspective. And you will see in this case how you need to take everything in perspective. Yeah.
In the reflexes in the upper limbs were 1 plus, the lower limbs 2 plus, plantars, flexors. Otherwise, sensory examination, cerebellar examination.
In reflexes, it's always better to say normal, exaggerated, depressed, absent, describe what, because 1 plus 2 plus is somehow clumsy. Okay.
So here, are you able to see the video of the gait? Hello?
Yeah. Yeah.
So he has difficulty in getting up from sitting position that I'm not able to show.
Okay, Vikram.
Yeah.
Vikram, let's ask some, Soro, let's ask somebody.
Yes.
So you see, in neuromuscular disorders, seeing the patient walk, extremely important. So, Dhaval, tell us what all did you find? You want to run this video once more for everybody's benefit? Soro, run it once more.
Yes.
And then you tell.
Yes.
Good. So make your observation, Dhaval.
Slightly wide base gait with waddling.
Placed is the word that you use for ataxias.
Yes. Waddling gait, sir, with high steppage and
Does anyone want to add anything?
Yes, sir.
Yes.
Sir, while walking, he is hip, abducting his hip joint, and then he's putting the leg forward.
Hmm.
So that is one point, and striking the heel first, then the toe.
That will be against a foot drop, no? That will be reverse of a foot
Yeah,
drop.
he is high stepping. He is raising the leg and then putting it.
See, once you have a high steppage gait, it is less likely that you will be heel first. You're making some observations, but you're not able to
Yes.
put them well. Okay. Once more, okay, maybe what shall we do? I will make a few points and then you again see the gate. Is that what we should do? Yeah. Now, when Saurav will again show the gate, see these points. Look at the way the feet are placed. In normal anatomical position, you have feet parallel to each other. Now see how his feet are placed when he's walking. They are externally rotated. What does that mean? That usually means a difference in the strength of external rotators versus the internal rotators. So the external rotators seem stronger than the internal rotators of the hip joint, the way his legs are placed. Then you notice that there is a foot drop. Obviously, it is high steppage and there is a foot drop, which seems slightly asymmetrical as the patient is walking. But the point that you made is correct, that his heel and toes generally touch the ground at the same time. It's not the floppy foot drop. It sort of comes down like that. Now, is there a contracture developing somewhere? Is there more weakness beyond the foot drop? That is what we need to see. Then you look at the hip area. He doesn't waddle like you see Duchenne dystrophy waddling. There is a little waddle. So you'll probably see abductors weak, but not very weak. Adductors are going to be very weak. And that's because the way he moves, the legs go apart, which somebody called a wide base gait. Then you look at how much lordosis is there. There's some degree of lordosis. It's not as much as you will see in Duchenne muscular dystrophy. Then you watch the upper limbs. The upper limbs are palm forward. Both upper limbs are palm forward, moving like that. You see the arm swing. It's a very unnatural arm swing. When you see palm forward and an arm swing like that, you know that these interscapular muscles are weak. So the rhomboids are going to be weak. The serrata are going to be weak. The scapulae are obviously winging. And therefore, the whole upper limbs sort of move forward like that. So when you look at this man's gait, the conclusions that you can draw are that there is a partial foot drop, one side more than the other. There could also be weakness of the plantar flexor muscle with some contracture at the tendoachilles. There is an internal rotator weakness. There is an adductor weakness. There is a mild abductor weakness. There is a mild paraspinal weakness. There is an asymmetrical scapular weakness. And you also see perhaps if you see the video from if you can get a good look at the feet and the hands, you see a lot of wasting there. There is weakness and wasting here as well as in the feet. Now, see the video again. Particularly see the arm swing, see the external rotation, see the little waddle, see the little lordosis. Yeah.
Dr. Saurabh, in case your video is sort of breaking, in case if you want to play it again, you can stop sharing and change the setting and start again if you want to.
What is everyone comfortable or?
Actually breaking in between, possibly because of slow internet.
Okay, just once again you show. Actually, it's going slower, so you appreciate it more.
So,
Right. Okay. So we have made our points in the gait and the stance and the way he is. And in neuromuscular disease, watching the patient walking the patient walk on toes and heels, sitting on a chair, getting up, lifting the arms up, closing the eyelashes, he gives you most of the information that you need. Right. So formal muscle power testing, you want to tell, Saurabh? I think, Saurabh, you want to go ahead? Hello? Yeah, by the time Saurabh comes up, let's answer one question. Somebody has asked that if the adductors are weaker than abductors, will waddle occur? Waddle will occur when the abductors are weak. Waddle has to do with weak abductors. What is happening to adductors doesn't matter. So waddle will come. So that's one question. Then Rakesh, you want to take more questions? Rakesh, are you there? Rakesh is there?
Yeah, he's there.
Yeah. So
You want to
somebody
take?
asked.
Saurabh, you tell us when you are ready.
Yeah.
Yes, sir.
So is EDB bulk preservation a point favoring myopathy rather than EDB wasting? In this case, it is mentioned EDB is wasted. So yes, I would say a good question. EDB wasted, normally you will consider the patient to have a neuropathy. Usually in patients of myopathy, EDBs are either intact or they are hypertrophied. But there are very few myopathies, which of course we'll be discussing, which can have EDB wasted. The classical distal myopathies can have a wasted EDB. So wasted EDB is not always neuropathy. You have to keep in mind myopathy, distal myopathy as well.
And anterior horn cell.
And of course, yeah, anterior horn cell, of course, yeah.
Yeah. Now, let me ask a question. Whom shall we ask? Vikram. What is your concept of distal myopathy? To you, what is distal myopathy?
Distal myopathies are either they are localized to the distal muscles, or sometimes they may.
To you, what is distal?
Distal is like foot and the hand muscles, rather than the semi-distal muscles.
So tell me one myopathy that affects foot and the hands.
So, foot and hand. No, sir. Most of them affect either the forearm or the anterior tibial muscle.
Right. So I think it is for everybody to appreciate that what we have been calling distal myopathy, the terminology is not accurate. They are semi-distal myopathies. And maybe Wellander's myopathy is perhaps the only myopathy that you see in the small muscle of the hand, and it doesn't go anywhere else. You need to take a biopsy from the small muscle of the hand. So most of the distal myopathies that we conventionally talk about, the Nonaka's myopathy, the Miyoshi's myopathy, Markbury, whichever you have, they're all semi-distal myopathies. Very important as a concept. Yeah. Right. Ready, Saurabh?
Yes, sir.
Go ahead.
So in between, can you ask one more question asked by a few exam students?
Yes,
How do you check the single breath count by every word or holding the breath and checking the time, so what exactly method you should employ for finding single breath count? And what is the importance of abdominal reflex, its pathway and significance for this case?
So in the single breath count, we tell the patient to hold a breath and then start, start with the numbers till one, till how much you can able to spell, like 1 to 30, 40. If it is less than 30, then it is affected, the single breath count.
Abdominal reflex, who wants to take? Rakesh. Abdominal reflex significance in this case. Rakesh, Bhagyadan. Normally in a lower motor neuron condition, would you worry about abdominal reflex?
Reflexes, no, will not worry about it.
Generally, no.
Yes.
But within a pyramidal tract, obviously you would.
Yes.
Having said that, some myopathy that particularly affect the external obliquus muscle do tend to reduce the reflex because the muscle itself is not working very well. And one such example is scalpenopathy. So if it's absent, it doesn't necessarily mean that you're dealing with an upper motor neuron, but it could be one of the uncommon myopathy.
So there is a question, what to ask for differential weakness in the history? Because it's a very important point favoring towards muscular dystrophy. So I thought one is, of course, if there is a waddling is one point, which will tell you that ABs are more weak than ADs. Second is, while getting up from the squatting position, if they can say that my thighs play out, it will be reversed. Thirdly, you can ask about inability to walk on the toes, which is again a very, very important thing. The patient can easily say that I'm not able to walk on the toes. You know that there is a classical differential weakness. And in the upper limbs, I'm not sure of any differential weakness questions you can ask at the history level. When you examine, of course, you'll come to know. But I think these are important ones.
I mean, I've said this many times, but my first patient of hip adductor weakness, his symptom was this. The first patient on whom I sort of started focusing on the adductors was that while driving my car, I can't move my foot from the accelerator to the brake. That was his complaint. And that was his only complaint. He couldn't adduct the thigh. Can't move my foot from the accelerator to the brake. Of course, then we started looking at them and all. Yeah. So they can be, like Dr. Singh mentioned, there can be pointers towards differential weakness. Foot drop itself is one of them. Yeah. Okay. Right, so.
Yes. So I go back to the power testing.
Yeah.
Oh.
You've shown it already?
Yes, sir.
For 1 minute I was away. Yeah.
Okay.
So if you showed it already, then just show it and make the points.
Okay, sir. So in the upper limb, at the shoulders, there is no much pattern. In the elbow, there is a differential weakness. The triceps are, the biceps are more weaker than triceps. And distally, the small muscles of the hand are weak and forearm muscles are weak. The hand grip is weak. In the lower limb, there is a significant differential weakness seen. In the hips, adductors are more weaker than abductors. In the knee, hamstrings are more weaker than quadriceps. And in the ankle, dorsiflexors are weaker than plantar flexors. And hence, the quadriceps are spared. In the upper limbs, there is winging of scapula and no specific pattern found.
Right. Okay. So this more or less matches with what we saw on his gait.
Yes.
Anything extra we found on examination? We probably confirm what we thought will come. Okay. Then reflexes and sensory
Yes.
and
Yeah. So the reflexes in the upper limbs, they were hyperreflexive, and lower limbs, they were normal. Plantars are flexors, and sensory examination, Romberg's and cerebellar examination normal.
right. You didn't find any fasciculations.
No, sir. No fascination.
So you want to sum it up?
Yes.
Any other points, Bhagyadan, you want to make before the summary? Bhagavan, anything you want to mention, or we go ahead?
So there is a
We
who
lost.
has, so there is somebody who has raised their hand. Do we allow them to talk?
Yeah,
Yeah, please.
certainly. But how do we know what do they want to say?
So the only way to actually find out is to allow them to talk.
Yeah, sure.
Okay, so we have
How many are there?
two.
Yeah.
Yeah, okay. Okay, so it's your time under the sun.
So Dr. Sagari.
Go ahead. Ask your question.
No, they've lowered their hand, and the other doctors not talking. I have given the permission, but they are not
Okay.
talking.
Later on, if they want, they can.
Sure. Okay, sir.
Fine.
Yes.
Okay, so Bhagavan, you want to say anything, or we put up the differential diagnosis?
We move ahead with differential, sir.
Yeah. Okay.
So, in the summary, the 29-year-old male born of non-consanguineous marriage with non-familial, insidious onset, gradually progressive, pure motor, symmetrical quadriparesis, distal more than proximal, lower limbs more than upper limbs, with differential weakness, as we saw in the lower limbs, with scapular winging, with wasting but no fasciculations, with truncal and neck flexor weakness, with ankle contractures, without any fascial or extraocular muscle weakness, without any sensory or bladder ball involvement.
Right. So, what is your differential diagnosis?
So, first, again, I would like to keep the muscle, and in which the etiological diagnosis I would like to keep as dystrophy.
No, I think just now you keep muscle disease. Then
muscle disease, second anterior horn cell disease, and third is a nerve.
All right. Now, at this stage, let's do the most important aspect of a lower motor neuron case. How does one differentiate anterior horn cell problems from the muscle problems? So, Bhagavan, you want to take it on? Bhagavan? You want to take it on, Bhagavan?
Yes, sir. So there
You
are
have
some.
a slide. You have a slide also, or you want to tell?
Better, sir. I will have to. Do you have the slides, Saurabh, which I sent you? Can you
Yes,
start?
Saurabh, I'll put them up.
Yeah.
So, put the table anterior horn cell versus muscle. That's probably the most important table. Okay, then we can start telling.
Slide number 8. It will be on slide number 8. One minute. So
you can start telling.
Few points which can help to differentiate between spinal muscular atrophy and muscle diseases. First is that weakness, wasting is out of proportion to weakness in spinal muscular atrophy. Fasciculations, presence of fasciculations, of course, it favors anterior onset disease. Differential weakness usually is absent. What we see in our case that there is a profound differential weakness across a joint, which is usually absent in spinal muscular atrophy. But the point we discussed that sometimes biceps are spared and triceps is weak. So this is also may not be entirely right. Deep tendon reflexes are depressed to absent even in muscles that show normal power. Sometimes in lower, only patient with lower limb weakness, the upper limb may not have any weakness, but in spinal muscular atrophy, the reflex may be absent. Muscle hypertrophy is usually absent, while we see that muscle hypertrophy or pseudo hypertrophy can occur in muscular dystrophy. One important point which sir may also agree, I was saying that fasciculated tremors of upper limbs, the shaky hands in a patient with weakness, usually they are characteristic of a neurogenic disorder. So presence of tremor in a patient with muscular weakness, I think this is one of the point which strongly helps to differentiate between spinal muscular atrophy and muscle diseases. Presence of fasciculatory tremors. If we see the pattern of weakness, then neck weakness, bulbar weakness, and asymmetrical involvement is more common in patient with spinal muscular atrophy. If CK levels are mildly raised and ECG is usually normal, we see that in many muscular dystrophies, there is cardiomyopathy. So even presence of abnormal ECG also can occur in spinal muscular atrophy, and the final is the EMG. Sometimes even after going through all the history and examinations in the EMG lab, you will be surprised that a patient with gradually progressive muscle weakness, they have neurogenic denervation. I think these are some of the points which can help to differentiate between SMA and muscular dystrophy.
Yeah, very nicely put, Bhagyadan. I think, like he said, the key is that you have to keep both. Don't get biased. Keep both. Objectively look at what you have. And you will find some cases so difficult that you can't make up your mind whether you're going to say anterior horn cell or whether you're going to see a muscle disease. So keep both. Pure motor, progressive, all four limbs, always keep both. You can be surprised again and again. And the more you see, the more surprised you get. So I think over these 30 years, I have come to this conclusion that, okay, these are classifications, these are guidelines, there are tables, but keep both. Keep more than two, actually.
So can I make one point, sir? Tremors, sir, they have never,
Yeah.
tremors, sir, they have never given me presence of tremor. Usually, sir, neurogenic, sir. They have
Amongst
never
various,
betrayed me. Only thing is, tremors have never betrayed me. Each and every point has been useless, but tremors have never betrayed me. If there are tremors, then till now I have seen around 8 to 10 such cases that everything goes towards myopathy, but in the EMG lab you will get to know that it is spinal muscular atrophy.
I think when you're absolutely right, when present, it is a very strong indicator towards a neurogenic process. It may be neuropathic, it may be anterior horn cell. But the problem with this is that very few patients have tremors.
Yes, sir, that is that.
So when present, it helps you.
It is very specific, but very less sensitive. But it is very, very specific.
That's absolutely correct. I entirely agree. Yeah. Okay. So what do we do next? How much time are you going to allow us, Rakesh and Devashish? What do people want? I mean, there is a large quiz coming up, and we already overshot our time. How do you want to do?
Fine, but it's going nice. So we'll keep continuing in the case.
Okay, fine. So let's go for a few more minutes and look at the different possibilities. So after looking at the table, you will keep muscle first or anterior horn cell first? Saurabh?
Yes, sir. So I would like to keep the muscle first.
Okay. That's because we told everybody that we're doing a muscle case today.
That's exactly what I was going to say.
Okay. Now let's tease it a little further. What sort of muscle disease, Saurabh?
So since it is slowly progressive, symmetrical over 4 years, and it is progressive, so first I would like to keep as a dystrophy. So a degenerative
Well, you just say an inherited myopathy.
Inherited myopathy.
No? Why do you say dystrophy? How do you define dystrophy? You know, this is one question I have found 50% of the DM exam going students cannot answer. And I have never understood why. Define a dystrophy.
So it is a chronic progressive myopathy secondary to some structural or enzymatic protein defect.
Good. There is one other word, inherited.
Inherited.
Chronic, progressive, inherited, primary disease of the muscle, which is usually due to a protein problem or an enzymopathy. Okay. So why do you say dystrophy? This is not inherited.
So it can be a sporadic mutation.
Right. So negative family history doesn't negate it. So what percentage of patients have no family history?
30%.
Depends on the population. The more consanguineous the population is, more is the chance that you will get a family history. lesser consanguinity in the population, lesser chance. Like in some populations, only 5% patients have a family. But in India, it is much more, at least 1/3, if not more. Okay. Now, what sort of muscular dystrophy?
Since it is slowly progressive, predominantly limb girdle syndrome with some distal muscle involvement.
Now, tell me one point. Whoever wants to answer this. When does a limb girdle syndrome stop becoming limb girdle syndrome? Question is, when does a limb girdle syndrome stop becoming limb girdle syndrome? Meaning, which features will tell you, oh, this is not limb girdle syndrome? What about foot drop? Vikram, is foot drop okay for limb girdle syndrome?
Yes, sir. Over time, they may develop a foot drop. Some of the limb girdle, like dysferlinopathies, FSHTs, they can later on develop
Is
a.
okay. Gastroc is okay. Forearms are okay. So when do you say, okay, oh, this is not limb girdle syndrome?
Sir, ocular and bulbar involvement.
Excellent. Ocular, bulbar. Absolutely correct. When these two things come, you are out of the limb girdle. Though there are very rare descriptions of limb girdle syndromes in one families, two families, who have peculiar gene mutations and who have these things affected. It's exception. Right. Otherwise, everything below the neck can come under the big umbrella of limb girdle syndrome. So are we going to call this a limb girdle syndrome?
Yes.
Yes,
So a limb girdle myopathy. Are you going to call this a limb girdle muscular dystrophy?
Yes.
Why dystrophy? What is dystrophic in this history? You don't know. It's a chronic limb girdle myopathy. May not be dystrophy. Could be because dystrophies are common. But there's nothing in the history or examination to tell you that this is one. Of course, there are some telltale features of one condition here.
So can
Anyone?
I make
Yeah, please.
sir, after going through examination, sir, there is profound distal weakness. Means upper limb distal power is weak than proximal power.
Good.
Lower limb distal power is weak than proximal power, and quadriceps is paired. So you have not thought of quadriceps pairing myopathy like GNE myopathy in such
Yeah, I
case,
have
because so much
kept
profound forearms, hands, they are so much wasted. In LGMD, everything means it can come, but when a patient is bedridden, only then only such forearm wasting and hand wasting will occur. In a ambulatory patient, if your hands are wasted and still your quadriceps are 4+, means it is almost normal, then have you thought of possibility of GNE myopathy?
Yes, sir. I've taught the possibility of GNE myopathy. I've kept as a lower down to
No,
LGM.
Saurav. Why lower down?
No, lower down. Why?
Actually, he presented with proximal weakness first, which is
Okay.
Okay.
point.
We give it to you. We give it to you, even though as you spend more years, you know that that doesn't hold much water. But
Just
we give
broad
it
terms,
as
is it
training
distal
goes.
myopathy or it is a LGMD? Saurabh.
Sir, I didn't get you.
Is it in broader sense? Is it are we dealing with a distal myopathy spectrum or a LGMD or a LGMD spectrum?
LGM spectrum.
I think for this, what started first gives you a lot of idea. GNE patients often start with the foot drop and they stay with the foot drop for a while. So what came first tells you which group is more likely. When you see somebody 10 years into the illness, 15 years into the illness, you may not be able. What started first? Now see, proximal weakness in India, it comes to light rather easily because we people in India, for various activities, we sit on the ground, daily activities are on the ground. So a little proximal weakness also comes to light early. And second point is, when the ankle is unstable, When the ankle is unstable, people have difficulty in getting up, which they may interpret as proximal weakness. But actually, their ankle is unstable. So that's something that you need to be a little careful with. Everything that has difficulty in getting up to the ground is not necessarily proximal. And this particularly happens in GNE myopathy. Their ankle is unstable. They have a foot drop. Right. Now, another hypothetical question is, when does a distal myopathy cease to be a distal myopathy? Just like when does a limb girdle cease to be a limb girdle? So the boundaries between distal myopathy and proximal limb girdle syndrome are arbitrary. You can have a distal myopathy, or in fact, most distal myopathies subsequently become proximal. And most proximal syndromes subsequently have some distal component. So it's not a hard and fast thing. But the point that Bhagyadan made about the severity of weakness in distal versus proximal is very, very valid. Here the distal muscles are very weak. The small muscles of the hands are weak. And then you get a grade 4 quadriceps. So these are features, strongly features of the GNE myopathy. Now, wasted EDB fits into GNE myopathy. Wasted FDI is often seen in GNE myopathy. So I think among different myopathies, we probably think that this could be a GNE myopathy. Yeah.
Sir, from the history, I was thinking, I mean, maybe it's a calpanopathy. It began proximally, there was ankle contracture, winging, but this hand wasting was
because of the winging of step.
really.
Yeah. I think what came first is very important. What came first is very important. Tendo-Achilles contractures are usually prominent in calpanopathy. But you are elucidating the phenotypic overlap. What you're saying goes hand in hand with the phenotypic overlap within various limb girdles. You know, is Madhuwala listening? If she is listening, she can raise the hand. Recently, what she did was, in a 100-odd patient, she did the muscle strength between muscle pairs, extensor versus flexor, adductor versus abductor. And the muscle pair analysis seems specific for specific diseases. Like in GNE myopathy, quadriceps versus hamstring comes to P 0.000 something. There is that much difference between the two muscles across a joint. Similarly, calpain has a pattern. Each one has a pattern. Sarcoglycan has a pattern. Collagen has a pattern. So we've called it muscle pair analysis, and she's publishing it somewhere. So if you keep that in mind, calpain will come in, but I think it will come after GA. You don't see FDI and you don't see EDB, and you don't see such a prominent foot drop in calpain. But anything is possible. Anything is possible.
One question, sir, can I ask?
Yeah, please. And then you show the GAD, you show the LGMD characteristics.
Yes, sir. Saurabh,
Yes, sir.
you have shown that patient has very profound upper limb involvement also. So can you name some myopathies that have predominant upper limb involvement?
FSHD starts with the upper limb.
Yeah.
Myotonic dystrophy.
Yes.
Sir,
Here, quadriceps is spared. Any myopathy which has upper limb involvement and quadriceps severely affected?
inclusion body mass.
Inclusion body mass. Any distal myopathy having only severe upper limb involvement?
Wallenders.
Any inflammatory myopathy having upper limb involvement? Is it possible for an inflammatory myopathy?
Cervicobric.
Body mass.
Good. Okay, so I think it's time to start winding up. So maybe, Bhagyadan, you show the LGMD clinical features.
Saurabh, can you go
Yes.
to that our slide?
Yes.
This is from one of our manuscripts in the journal Practical Neurology.
This one, sir?
But this one, yes. So in muscle disease, which feature structures are, we are only discussing about thing that which structures or which muscles or what is the pattern of muscle involvement. So in all the muscle disease, like in LGMD also, it is very, very important. So these are few clues that can help to narrow down of a differential within an LGMD. Of course, we are going to get a genetic testing done, but these are some points which we need to look for, which will help to narrow down our differentials in limb-girdle muscular dystrophy. Like we grow from head to toe, like predominant upper limb girdle involvement is usually, we have already discussed that it is very, very important feature of calpainopathy, but it can also be seen in enoctaminopathy, sarcoglycanopathy, and Fukutin-related proteinopathy. Biceps lumps presence is very important, that it helps, it favors points towards dysphalinopathy. Respiratory weakness is very, very rare in LGMDs, but very early profound respiratory weakness can point towards myotic. It is basically, it points towards LGMD type 1, autosomal dominant types of LGMDs. Truncal weakness again in calpainopathy, dysphalinopathy, and sarcoglycanopathy. Cardiac involvement, if it is present, then it usually indicates our autosomal dominant LGMD, like laminopathy, myotelinopathy. Also, it can occur in sarcoglycanopathy or dystroglycanopathy. Quadriceps on diamond on quadriceps signs, we know that it, if present, then it favors toward dysphalinopathy. Hip abduction sign, already sir mentioned that it was first observed in sarcoglycanopathies, but also later on it was also observed in other LGMDs like calpainopathy. Calf hypertrophy, which is considered a very important sign of DMD, it can also be found in other LGMD subtypes like sarcoglycanopathy, cavulopathies, FKRP, and telethinopathies. Prominent contracture, again ankle contracture, very, very suggestive of calpainopathy, but uncommon types like laminopathy, myotelinopathy can also have ankle contracture. Distal muscle weakness can also be seen in LGMD. If anterior compartment is more involved, then myotelinopathy, desminopathy, and tetinopathy should be considered. And in posterior compartment, we know there are two diseases only, dysferlinopathy and NO5 mutation. So these are not very sensitive, but if it is present, then you can tease out between different forms of LGMDs. So that can be helpful in some patients.
So I think what we will do, this manuscript I will leave with Saurav. Saurav, tomorrow I'll send it to you. Whoever
Yes.
wants to take it from Saurav can take it and use it.
Yes.
Sir, there are a few questions.
Yes.
They are quite difficult. I think we'll have to take them. Why there is differential weakness in myopathy? That is first question.
Yeah, that is asked by Dr. Kaul, sir.
Yeah, Dr. Kaul has asked that.
Subhash Kaul.
Yeah.
Yeah.
Yes, sir.
Subhash, you're not allowed to ask difficult questions. Okay. Can I take that one? Or
Yes,
Vagidan
sir, you
No,
can.
sir, please, sir.
You
Please.
take, sir.
Right. You know, it seems that the dystrophy cycle is differently timed for different muscles. So some muscles enter the dystrophy cycle before the others. So depending on when you are seeing that individual, how far is the cycle of dystrophy gone in that muscle will decide how weak it will be. So in other words, individual muscle is like people. You know, even though they're all people, they're all muscles. Each one is different. So each one is affected by the process differently. Now, the real answer to your question will be to understand how the genes manifest differently in different muscle groups, to which there is a limited knowledge. But there are some postmortems of Duchenne children where they have looked at the dystrophy grading. And when some muscles are completely gone, the diaphragm had just started becoming dystrophic. So within the human body, it seems that the dystrophy cycles are differing for different people. And one of the focus of research is this, as to why these cycles differ. And if we can know that, we will probably know how to retard the process. So That's up to that, I think, is known.
Then, sir, why GNE is common in India?
Why GNE common in God? Who's asked this question?
There's-
Yeah.
no idea.
Yeah, again, Dr. Kaul student.
Dr. Kaul.
Okay. Okay. There are more questions arising out of this question. If you look at the genetics of GNE, I mean, it's autosomal recessive disease, and the common answer will be that Indians follow the intracommunal exogamy, and therefore autosomal DCS are common, and therefore GNE is one of them. But if you look at the genotype of Indian GNE patients, there is an absolutely mind-boggling, outstanding predominance of a single gene called WAL727. 90% of the people with the diagnosis of GNE myopathy will either have one or both allele as WAL727. You go outside India, and WAL727 is found very less often. It's seen in Thailand, it's seen in some other Asian countries, but it is seen predominantly in India. Now, about 1% of Indian population harbors WAL727. So that leads to a larger question. Is WAL727 just a population marker? If it is a disease marker, how pathogenic is it? And more people feel that the most common gene found in GNE myopathy in India is less pathogenic. And they don't know what gives the pathogenicity of GNE myopathy. The GNE gene is supposed to reduce the sialic acid. But when you supplement sialic acid, patients don't get better. So there are a whole lot of questions in this myopathy. What is the primary problem? Which is the gene responsible in different populations? If you look at our Rajasthani patients who we published some time ago, they share the GNE gene with the Roma gypsies. All the European Roma have the same gene that Rajasthani people have, and that's a homozygous state. And that's a highly pathogenic gene. Similarly, there are at least 8 founder mutations known in GNE gene in various populations. So it's autosomal recessive disease. Like other autosomal recessive, this is also common. But there seems to be far more to this WAL727 story, which is unsolved, and pathogenicity of the GNE genes, and the pathogenesis of GNE myopathy. It may be that these are just markers and the real gene is somewhere else. So they actually need whole exome. Because there's a whole lot of GNE patients in our collection also, in whom you find a single pathogenic allele. You don't find the second allele. Now, is the second allele intronic? Is it a copy number issue? So those are the complexities.
So there is a question, which are the myopathies with fasciculations?
The only one is thyrotoxicosis. Thyrotoxic myopathy fasciculates so much that it can look like ALS.
And sir, to complete the last,
caveolin.
Second is question.
Second is caveolin.
Sir, have you
Caveolin,
seen
okay.
It's not fasciculation, but it's a rippling muscle disease, which
Sir?
you may think is fasciculation.
Sir, have you seen any caveolinopathies till now?
Only
Yes,
one. Only one. It's a Middle Eastern patient.
And sir, somebody's asked, in this era of genetic diagnosis, what is the relevance of such detailed muscle examinations?
Self-satisfaction.
Is this person passed DM or not passed DM?
Yeah, of course you have to ask them.
If he has not passed DM, then it is very, very important for him, because his examiners will ask him which muscle is affected. Once you pass your DM, then the significance is there, because it is extremely important from the rehabilitation point. See, genes don't walk into your rooms. Patients walk into your rooms, and they keep telling you what the disabilities are. So their muscle examination tells you what are you going to do for them till actual therapies exist. Is the ankle more unstable? If the quadriceps is good, your rehabilitative measures are going to be different. So they are useful, but they are not that useful diagnostically because you can look at so many genes. But the more you look at genes, the more problematic it becomes. For example, I've recently got half a dozen patients in whom 3 or 4 pathogenic mutations in different muscular dystrophies are seen in the single patient. There is a calpainopathy, there is a laminopathy, there is a GNE-MAR. Now, what's doing what? What's the pathophysiology? What are you going to tell his brothers and sisters? So, I think each component that you can check is important. The history is important, the examination is important, the investigations are important, and you will have to take a holistic view of all this to be able to guide your patient best. Now, depending on how much time you have and how much interest you have, you will decide what you're going to do. And as time goes by, things will change. Like muscle biopsy, from a more important test, has now come to a point where if the gene doesn't give you a diagnosis, you come back to the biopsy. So everything is dynamic. It will keep changing. Yeah.
I think we're through with the questions.
Yeah. So shall we close at that? Thank you very much, Rakesh, Bhagat, Saurav, Vikram.
So there is a quiz. I'll run in very quickly.
Yes. And we hand over to you, Rakesh, for the quiz. Yeah. Rakesh and Devashish. Yeah.
Yes, sir. Fine,
Great.
sir.
Yeah.
And it was wonderful.
It's indeed wonderful. Should I share my screen?
Yes, please.
Yeah, sure.
So you have to first download that Slido app. And in case if you have not downloaded the app, you can just log in directly into your browser, slido.com, and I'll be telling you a code. Just enter the code, and that code will take you to the next page where you have to enter your name. There will be on the right upper corner, there will be a logo. Just click it, edit your profile, and enter your name, and then click on the polls, and then just wait. Once the slides will come, it will automatically come.